Now, for our first injury, let us focus ourselves on the sciatic nerve. Since it is the largest nerve in the body, it is bound to be injured or be affected in some way. So for the sciatic nerve injury, this usually is caused by stab wounds, trauma, fractures of the pelvis, posterior dislocation of the hip joint, or badly placed intramuscular injection in the gluteal region. It can also be caused by impingement of the nerve directly. So the first condition that we will discuss is sciatica. So this condition is wherein a bulging herniated disc compresses on the sciatic nerve, and this would cause numbness or pain on the ipsilateral side from the gluteal region down to the lower extremities. So this is fairly common in clinical practice. So pain from sciatica radiates from the buttocks down to the leg and can travel as far as the feet and toes. And also disease or condition is due to the piriformis muscle. So any inflammation or any condition that concerns the piriformis muscle to inflame would cause impingement to the sciatic nerve and would again induce similar symptoms such as the sciatica. So another is the wallet neuritis, in which males, so there's an article in PubMed published concerning the frequency of males going to the doctor complaining of ipsilateral pain. Another instance of injury to the sciatic nerve is through deep IM. So if you're careless and you just inject the medicine on the buttocks without realizing the location of the sciatic nerve, then you can injure that nerve and damage that nerve permanently. So safe way to do this is to inject it on the upper part, the lateral part, then the sciatic nerve would be avoided. So for the management of these conditions, we must first approach the causes. So if it is trauma, then appropriate management to that area is needed. If it is just inflammation of the muscles, then we could use heat therapy, cold therapy. We can also use non-steroidal anti-inflammatory drugs such as your mefenamic acid, ibuprofen. And if it's that severe, then we could go to surgical procedures, especially in sciatica when there is nerve impingement. So we could do microdiscectomy, wherein the herniated disc is repaired so that it won't impinge on the spinal cord, it won't exert pressure in the spinal cord. Also, if the concerned structure is the lamina, we can also do the laminectomy, which will remove the lamina of the spinal vertebra. Now, the next structure that can be affected is the superior gluteal nerve. So it is also a branch of the sacral plexus. It enters the gluteal region from pelvis through the greater sciatic foramen, and it is above the piriformis. It runs between the gluteus medius and minimus, and it innervates the muscles gluteus medius and gluteus minimus. So if this nerve is injured, the muscles that are paralyzed is the gluteus medius and the gluteus minimus. So motor loss of this muscle would lose the ability of abduction of the hip, and unilateral injury shows positive Trendelenburg sign, which I will show in the next slide or the next video. So this is the drooping of pelvis on one side when ipsilateral foot is lifted off the ground, and the bilateral injury shows waddling gait.
During the stance phase of the gait cycle, the gluteus medius works to maintain both hips at the same level. What is Trendelenburg gait? Trendelenburg gait is an abnormal gait that is usually found in people with weak abductor muscles of the hip, which are supplied by the superior gluteal nerve. Here you can see a patient example of Trendelenburg gait. The patient could not abduct the right hip due to weakness of the abductor muscles on the right side. If the patient has weakness on the one side of the pelvis, and when the patient stands on that side, the pelvis on the contralateral side will drop. This is called the Trendelenburg sign. The gluteus medius is very important during the stance phase of the gait cycle in order to maintain both hips at the same level. The stance phase accounts for about 60% of the gait cycle. 3 times the body weight is transmitted to the hip joint. The hip abductor actions account for 2/3 of the body weight. We identify the weakness stance phase if the pelvis drops to the opposite side. Here you can see an example of weakness of the abductor muscle, as well as avulsion of the abductor muscle tendon.
Notice how in the gait, how whenever he loads his weight onto his left foot, his right hip drops down and towards the affected side. So in this case, we would be demonstrating a Trendelenburg positive sign. This patient has a positive Trendelenburg sign, meaning that their left hip abductors, such as the gluteus minimus and the gluteus medius, are not working properly.
The next structure, the inferior gluteal nerve. This is also a branch of the sacral plexus. It enters the gluteal region from pelvis through the greater sciatic foramen below the piriformis. This runs between the gluteus maximus and medius, and it innervates the gluteus maximus muscle. So if this one is affected, the gluteus maximus muscle is affected, and there will be motor loss. So there will be impairment of hip extension and lateral rotation, and difficulty in raising the body from sitting or stooping position. So they have this condition called inferior gluteal nerve palsy, which also has a gait. So I will show you on the next video.
Gluteus maximus gait. What is a gluteus maximus gait? When the gluteus maximus muscle is weak, the trunk lurches backwards. There will be extension of the trunk. It occurs at the heel strike on the weakened side to interrupt the forward motion of the trunk. This compensates for weakness of hip extension. This is the gluteus maximus muscle. It is the largest and the most superficial of the 3 gluteal muscles. The other 2 muscles are the gluteus medius and minimus. The gluteus maximus has its origin from the gluteal surface of the ilium, from the lumbar fascia, from the sacrum, and the sacrotuberous ligament. The gluteus maximus is inserted into the gluteal tuberosity of the femur and the iliotibial tract. The gluteus maximus muscle is supplied by the superior and inferior gluteal arteries. It is innervated by the inferior gluteal nerve, L5, S1, and S2 nerve roots. The function of the gluteus maximus muscle is external rotation and extension of the hip joint. The muscle supports the extended knee through the iliotibial tract. Here you can see the position of the tensor fascia lata muscle and the iliotibial tract in relationship to the gluteus maximus muscle.
Now, for the management of these nerve conditions, nerve injuries, it will be really on a case-to-case basis. So if the patient needs surgery, or if the nerve is lacerated, it can be repaired within 72 hours so that better outcomes will be achieved. But there's really no data on the statistics for the prognosis for these conditions that are being repaired. If there's an inflammation, you can take an anti-inflammatory drug, or we can also give steroids. But again, there's no statistics. Also, physical therapy and rehabilitation can help the patient in its in the nerves recovery. And there's also a possibility that the patient will live with this condition for life. So that's it, and thank you for listening, and thank you for joining us in this class. So this will be my last lecture for you guys, and I hope you do good and become successful doctors in the future, and hope to see you soon in school. So goodbye and thank you.